Yeah. All right. Well, it's good to be back here. My name is Sarah. Janice, I know, introduced me last month. My name is Sarah Langston. I'm Stroke Outreach Coordinator for the University of Kansas Health System. And so the presentation that we brought to you today is Dr. Gregory Herman, who's over here, one of our rehab medicine physicians at the hospital. And then also we have Megan Turk, who is a physical therapist for the University of Kansas Health System. And so they are going to be presenting to you on spasticity and doing some stretching with you all today. And so one last thing I'd like to say is that if you ever have topics that you want to be seen, please let Jeanette know. She's been giving those to me, and we hope that our 2020 calendar is all that you want. So thank you so much, and let's welcome Dr. Herman.
Hi, thanks for having me out here. So my predecessor, Dr. Rakesh Bharti, was very involved in this group, so he had moved closer to family. I stepped into his role when I finished training and look to be involved with you guys hopefully in the years to come. So today's topic, spasticity following stroke. So we'll just kind of take a high-level overview, talk about some of the different treatment options that are available, and then Megan, our physical therapist, will work with educating you guys on some stretching in particular, and then happy to answer any questions that you all may have. Technical difficulties. Yeah. Okay, helps to turn it on. So today's agenda, like I mentioned, will first of all define spasticity, and then secondly talk about some of the specific symptoms related with that diagnosis, and then talk about treatment goals and options. Okay, so first I think it's important to understand that spasticity falls under a broader syndrome that's described as upper motor neuron syndrome. It's basically a fancy term for any kind of injury or insult to the brain or spinal cord. So when we talk about the syndrome, upper motor neuron syndrome, we usually describe it as either in the context of positive symptoms or negative symptoms. Basically meaning the presence of a symptom versus the absence of something. I'll explain in a little bit further detail. So, for example, positive symptoms would be the presence of spasticity, for example. Muscle overactivity, exaggerated muscle reflexes, muscle spasm, which is slightly different than spasticity itself, abnormal muscle tone, and I'll describe this in detail, and then rigidity. So most of these are related to abnormalities of muscle tone, including spasticity. So negative symptoms of the upper motor neurons syndrome: slow movement, or bradykinesia as we call it, muscle underactivity, decreased dexterity, so fine motor impairment, overt weakness, and then ultimately paralysis and muscle fatigue as a result of some of that underactivity, or overactivity for that matter. So as I mentioned, spasticity is a positive symptom of the upper motor neuron syndrome. And in its truest definition, it's an abnormality that can be defined as an increase in resistance to velocity-dependent stretch. So true spasticity is resistance to quick, rapid movements of the muscle. And then it's associated with that increased reflex of the muscle stretch. Okay. So some of you may be saying, well, my spasticity is present whether or not I'm actively or rapidly moving my muscle or not. Even at rest, that muscle is tight and overexcited. And it's really a terminology distinction, but I think this is helpful to explain all abnormalities of muscle tone. So in the middle here, I'll try this light. So this is normal, okay? Initially after stroke, you're going to have what we call flaccid or hypotonia, so basically low tone. And then as time progresses, you're going to develop some of that spasticity, which is hypertonia. And then ultimately, if it's not treated appropriately, we can become rigid or get contractures of muscles and joints. So how common is this as a condition in post-stroke population? So we see it in anywhere from 17 to close to 50% of the post-stroke population, so very, very common. If we expand the definition to basically include any patients who have subjective complaints about muscle tightness, then we're all the way up to nearly 60%. And the population within the stroke community that sees more spasticity is typically those who have a stroke at a younger age, who have a hemorrhagic or a bleeding stroke as opposed to an ischemic or basically blood vessel occlusion. So that's just trends, but this can happen in any particular stroke patient, for that matter, any patient who's had injury to the brain or spinal cord for any reason whatsoever. Typically, we are seeing this develop within the first 3 months after stroke, but it can occur even sooner. So I've seen it as soon as 5 to 7 days when patients are still acutely hospitalized after a stroke. Okay. So physical consequences of the spasticity. So as you might expect, normal movement is impaired. So our range of motion is diminished. We can also have inappropriate movement and excessive movement as a result of that tone that doesn't really serve the purpose. It can be burdensome and ultimately painful. So a common presenting symptom of spasticity is muscle pain at night that's awakening in the patient, and pain with movement, of course. And then this pain and limited range of motion can be demonstrated whether or not the patient themselves are trying to move the limb, or even if the therapist is passively trying to move the limb. So it can get in the way of walking, dressing that the patient is performing, or it can get in the way of having a caregiver provide assistance. And if a patient particularly needs help getting dressed, help with bathing, help with any day-to-day activities, that spasticity can really interfere and make life more difficult. Ultimately, as I mentioned earlier, if it's not treated, we can get damage to the muscle, weakening of the muscle, and then ultimately contracture of the muscles and joints. So how do we assess this? Well, typically the patient is the one reporting their symptoms and describing how it's interfering with their daily life. We have some laboratory measures we can use with some of the clinical scientists, where they can use some recording instruments to assess how hyperexcitable that muscle is. What we typically do in an exam setting or in a therapy setting is basically do a range of motion analysis. And then we have some grading scales that we use, and that's helpful to assess where we are at the time of the initial evaluation, and then also how effective our treatments are. Our therapists will also do some specific tasks where, for example, they might ask you to do some timed motor activities, and again, that just gives us some objective data as far as spasticity is interfering with function. But ultimately, this is a quality of life issue, and so the most important information we get is from the patients on a day-to-day basis, telling us how that muscle tightness is interfering with their day-to-day activity. This is just one of the scale. It's a very kind of rudimentary 0 to 4 scale of how we will measure tone in clinic. So the goals of treatment methodologies, as you might expect, it's to improve our mobility and our range of motion. It's to decrease some of those painful symptoms that we're experiencing along with that muscle tightness, decrease the spasms that can interfere with our day-to-day activities. For many of our patients who wear orthotics, for example, for foot drop, it can make it easier to tolerate wearing those devices, and therefore hopefully make it easier to walk. Some of our positions that we have as a result of the spasticity, so if we have arm flexion contractures or spasticity, or what we call ankle plantar flexor tightness, it can be unsightly, and so hopefully we try to improve the appearance alongside the positioning. I'll get into some treatments in particular here. So number one, above all else, and you guys are already on the right track, stretching is the most important thing we can do. It's the most beneficial thing we can do to prevent further development of spasticity, and the best thing we can do to improve our range of motion. So that'll be a common refrain throughout this talk, and Megan's talk. Stretching is number one. We can also do some specific braces that we can wear, particularly at night, to try and maintain our range of motion. There's casting. This is done more often in the pediatric population, not as much in the adult population, but this is a series of, like it sounds, of getting casts to try and restore range of motion. I typically don't recommend this in my clinics. Electrical stimulation, so there's some instruments that our therapists will use to try and restore muscle activity so that we can, again, regain that range of motion. And then just trying to stay active and use the term use it or lose it is applicable when it comes to muscle tone and tightness. So being here at a community center and trying to stay as physically active is definitely to the patient's benefit. So when do we decide to treat? Well, number one, if it's interfering with our quality of life, so care, comfort, positioning, function. Typically, we go from the least aggressive to the most aggressive as far as treatment options. So stretching is the least, and I'll get into some of the more interventional treatments that we offer as well. Early treatment and stretching can prevent the ultimate thing that we want to avoid, which is contractures of the joint. For some of our patients who may have cognitive impairments as a result of the stroke and might not be able to perform all of the activities that they used to, getting dressed, getting to the toilet, and they require their loved ones or caregivers to provide support, treating that tone can make a big difference in quality of life, not only for the patient, but for the caregiver in performing those day-to-day activities. So that's another reason to treat it. So this is just kind of a graphic explaining, or I shouldn't say explain, but listing some of the treatment options. I'll get into some of these in detail, but in particular, we'll talk about some of the drugs that are available in addition to the rehab, both oral medications that we can inject into the muscles, and then some different devices, one in particular that some of my colleagues in anesthesia and neurosurgery can implant, and then I can help manage. I told you stretching was going to be up here a lot, so I just threw that in as a reminder. So stretching, right, number one. We talked about some of these other options from a non-invasive standpoint. So we'll talk about drugs, medications that we can take. Typically, there are 4 go-to classes of medications or specific medications. Baclofen is probably the most common. It's a medication that works on the central nervous system. It works on a receptor that pretty much down-regulates the activity, the overactivity of the nervous system that's leading to that spasm. So baclofen is probably the most common drug, and if you hadn't tried a medication, it's probably where a physician would start as far as treating. Benzodiazepines are another class of medications that work on a similar receptor. Sano Flex is another medication that works on the central nervous system. And then we have one medication that works outside of the central nervous system. So again, the central nervous system is the brain spinal cord. So that's where the first 3 medications listed work. The 4th medication works more locally at the muscle level itself. So baclofen, I think it's important to note that this is a medication that you do have to take multiple times throughout the day. Typically, we dose it 3 to 4 times a day. It's metabolized in both the kidney and liver, so it's important to make sure that from those organs, the standpoint of those organs, we're healthy and that we're monitoring their function. Unfortunately, very little of this medication gets to where it needs to go, and that'll be important when I talk about some of the other options that are available. But basically, our body has a well-designed system to limit the chemicals that are infiltrating our central nervous system when we take medications by mouth. And that system is sometimes a little too effective at keeping medications out of the place where they need to go. Primary side effects, some of you who take this medication can attest to, it can make you drowsy, sedated. So typically we try it to initiate the dosing at nighttime. But the body will often respond well and gradually become accustomed to that medication. And we're limited in the dosage because of some of the side effects that I mentioned. So 80 milligrams is the dosage that we use. So because the body is so effective at keeping that medication basically regulated in the brain and spinal cord, some of my colleagues are adept at implanting what's called an intrathecal baclofen pump. And what this is it's tough here with the lighting, but it's a pump that basically has the medication within it, and that travels through a catheter into the epidural space. And so this is basically making sure that that medication is getting direct access to the central nervous system and is dispersing and absorbed where it needs to be, so that we're getting more effective dose administrations without some of the side effects. Okay. This is effective for severe spasticity, and in particular, it's very beneficial in patients who have spasticity of the lower extremities, just because of where the lead itself is placed, gravity doing its work, the medication will titrate or will flow down. And so for patients who have tightness of the arms, hands, shoulders, this is not quite as effective. The programming can be manipulated so that dosing can be delivered at more problematic times of the day. This is just another picture of the pump itself. The actual pump is implanted in the abdominal cavity, and then the catheter is, as I mentioned, inserted in the spine. The maintenance for this is probably the most important thing. So you need to see your doctor on a regular basis to get the pump refilled with the medication. And then additionally, after it's implanted, there is a pretty intensive process where we have to titrate the settings or manipulate the settings to get the dose up to where it needs to be. Okay. So the second class I mentioned, medications, is called Benzodiazepines. Probably heard of these in their brand name forms: Valium, Ativan, Klonopin. So these do work well at the level of the central nervous system. However, they have some of those similar side effects as the baclofen, which we mentioned. So somnolence, being tired, can impair coordination, concentration can be impaired, and also the problem, I said, patients like it too much, they can be addictive, so it can be very hard to get off of these medications once you're on them. Different formulations will work for different times within the body itself, but typically dosing is multiple times per day. Just for the sake of completeness, Sano Flex is another medication that we'll use typically if we're not getting good response with baclofen. Unfortunately, the duration of action of these medications, of this medication, is short as well. So as you've seen a trend here, these medications require multiple dosing times throughout the day, which can be cumbersome. And the side effect profile, again, these are all acting very similarly in the brain. And so somnolence, fatigue can kind of work against some of our goals and desire to stay active and basically impair our quality of life. Now, there is one medication that I mentioned works at the muscle level itself. I will say, unfortunately, I haven't seen as great of a response in spasticity to this medication, but it can be worth a shot if we're not having success with the other oral medications. And some of our other interventions that I'll talk about shortly aren't available to the patient. This is a medication that is metabolized in the liver, so it's very important to monitor the liver function if we're using that. Okay. So one of the more popular treatment options, once we have essentially failed oral medication, so if we haven't had a good response or the side effects are too burdensome to deal with, are injectable toxins into the muscle themselves that will hopefully promote improved range of motion. And so these are done in a clinic setting. I'll talk about some of the specifics. These are all names of different toxins that all work very similarly at disrupting the communication between the nerve and the muscle themselves. So the nerve telling our muscle to contract and overactivate when it shouldn't, these toxins injected into the muscle will disrupt that communication and hopefully restore some improved range of motion. So not to get too technical here, but this is a cartoon of the nerve and the muscle receptor. These little dots are the neurotransmitters that will tell the muscle to contract, and essentially the toxin will disrupt the so that we can restore range of motion. So pros and cons of Botox or any of these injectables is that we'll start with the pros. So we can inject those specific muscles that are causing problems for the patient. So we can deliver a very targeted treatment without the systemic side effects, ideally. We can hit certain muscles harder than others. So for patients who might have more tightness in their hamstrings, for example, as opposed to their calf muscles, we can deliver a higher dose in the hamstrings and only a relatively smaller amount in the calf muscles. So generally, these are well-tolerated injections. They're done on an outpatient basis. Primary risk would be anytime we insert a needle, there's risk of bleeding, infection, but generally, these complications are very rare. So the cons is that these toxins will wear off or wear out, and the body will essentially eliminate them completely from the body within about 3 months. So these are injections that would need to happen typically on average every 3 to 4 months to get maximum benefit. Now, it's not really a side effect, it's actually the intended effect is to weaken the muscle and disrupt that overactivity. If we were to deliver too high a dose in a particular muscle, it is possible that we could have weakening to the point where we could have difficulty walking or doing what we need to do. And then the expense on here because it is costly, although if it's medically indicated, insurance and Medicare will typically cover it. So just a few examples here of what I'll typically see in clinic. So very common to have finger flexor spasticity, and this can not only painful, restrict range of motion, but as those fingers continue to dig into the palm, we can have skin breakdown. So those are all good reasons to treat this. So number one, what are we going to do? What do we always do for spasticity? I see you doing it right here. Stretching, exactly. So that's number one. I messed up my own slides here. First, I'm gonna measure how tight you are, of course, and then I'm gonna teach the stretching. We can use splints, right? So we can order a splint that you could wear at night. We could do Botox. We could do oral medications. This is less common. This is called a striatal toe. So you can just see that big toe that's hyperextended there. I will measure this. I'll teach you to stretch. Megan will teach you to stretch. We'll do the taping potentially. This is a good focal target for Botox. You wouldn't want to take an oral medication with all of those side effects when we can just isolate the particular muscle and knock it out, so to speak, so that we can restore normal range of motion. Ultimately, there are some surgical options that I'm not going to address today. I'm not a surgeon, but typically that's not anyone's first choice, so we leave that for the very end. This gentleman here is a hyperextended leg and plantar flexed foot. You can see that ankle is contracting. So I'm going to measure. We're going to teach you to stretch. We're going to try oral medications. This is another patient where we might do Botox into those calf muscles that are causing that positional abnormality. We can try a brace. And then this patient does have tone in their arms, but for the sake of educational purposes, if they only had that tone in the leg that was very bothersome, this could potentially be a candidate for a pump for management of that tone. Okay. And then similarly, this is an upper arm flexion pattern that we see. So stretching, bracing, oral medications, Botox. Backlift, the intrathecal backlift and the pump, not necessarily as beneficial in this patient with the upper extremity tightness, but it's on the list of potential treatment options. And then one more reminder for stretching, which I think leads as a good segue to our physical therapist today. I'll let her present and then happy to take any questions at the end of her presentation. So thanks for your attention. Appreciate it.
Thank you. coming in today. I think we're just gonna switch over.
Yep. Sorry about that.
I don't have any great jokes like Liz was telling me earlier. Okay, so as Dr. Herman talked about, we know that spasticity is a condition in which certain muscles are continuously contracted. And this contraction causes that stiffness or tightness in those muscles, and that can interfere with normal speech. And as physical therapists are always biased and always talking to you guys about is your gait. We're always obsessed with that, right? Always looking at that all the time. And he went over the cause of this. And what we really are looking at now that we know the cause is that increased muscle activity all the time, right? But what we really want to know now that we know the cause is what does it feel like? And that's not only important to you, but it's important to the therapists that are treating you, and it's important for you guys to share with the caregivers too, right? Because they need to know how to help you. Not only so that you can share what it feels like every day for you to move, but so that they can help you stretch out, right? Because stretching is how you're going to move better. How they can help you get through everyday life a little bit better. So what does it feel like, guys? I mean, it hurts, right? It's hard to move. So spasticity might be just as mild as just a little bit of tightness, or it can really hurt. It can be as severe as a muscle spasm that can knock you off your feet, right? This muscle tightness can make movement just a little less precise, because if it's not as smooth, then it's going to be harder to control your movement. And these involuntary muscle spasms can occur all the time, right? You can't control when they happen. And this increased muscle activity, I mean, you're tightening this muscle all the time, and that's exhausting. So it wears you out, right? You're more tired all the time. So how does this picture make you feel, right? You're relaxing on a beach, right? This is how I want to feel all the time. Totally relaxed. This is how we want our patients to feel when we're treating them on a beach. So this is the environment that we're shooting for. This is where I want to be right now, right? Who else wants to be here right now? I do. How about this? How does this picture make you feel? This is what I sat in on my way to work today. This is what spasticity feels like, right? What does your muscle tone feel like with spasticity when you're in this environment? Tense, right? Your muscles are super tight all the time. As compared to this picture, you're relaxed, loose, right? So what's the difference between this picture and this picture? Spasticity is the difference, okay? So we want to shoot for this environment, not this environment when we're treating spasticity. And that's what I want you guys to share with your therapist, with your doctor, with your loved ones, with your caregivers, is that you want this environment all the time, okay? And you, when you're feeling spasticity, feel like this, okay? Because people have dealt with traffic, and people know what beaches feel like, right? And they can picture the difference between the two. And that's what spasticity feels like. So now what? Now what do we do with that information? Physical and occupational therapy, our goals are to find that environment for spasticity and reduce muscle tone and lengthen the muscle and increase mobility to improve your comfort. Those are our goals. So therapy may include, like Dr. Herman said, stretching, lengthening, stretching exercises, tempering muscle, bracing, limb positioning, cold packs, electric stimulation. But we know that spasticity can't be stopped, but we can fight it through those things, okay? But it's in your control. So stretching's the key. So these are the guidelines that we have to follow together. Do all these movements slowly and gently. Never force or overstretch the muscle when we go through these exercises, okay? Fast movement will trigger spasticity. It will make it worse. So you have to move slowly. No bouncing, okay? So when you think of stretching, you know how people out here and they bounce? No bouncing, that'll make it, okay? So prolonged stretch. So you want to move into the movement and hold it. So you're going to move into the movement, go to the very end of the range. So think of stretching your muscle out, go to the very end of the range as far as you can go, and then hold it. Because our goal is to go to the very end of the range that you can go and lengthen that muscle. So don't bounce when you get there, okay? And then here's my favorite one, and I tell patients this, therapists this, caregivers this, everybody this. When you touch a limb, you want to touch a limb slowly. So when you touch a patient or an extremity, you want to touch a patient slowly. And then when you let go of a limb, you want to let go of a limb slowly again. Because how many times has somebody touched a spastic limb, somewhere where you have spasticity, and they've touched it real quick, and your limb's gone, and it's curled back up, right? Because that increases spasticity, okay? So you have to go on real slow and let go real slow. Think of that picture again, okay? We're aiming for a relaxation, okay? If somebody catches you off guard and scares you, your whole body's gonna tense up. It's the same idea, okay? So I'm gonna go through just basic range of motion exercises. We're gonna target each one of the joints. So the first joint that we target is that ankle joint, and that ankle joint is what really can affect your gait. So passive range of motion of the ankle, you're gonna place one hand, and you can even do this passively yourself, or you can have someone help you out if you have trouble. You're gonna place one hand on the heel, right here, and the other hand on the ball of the foot, and gently move your foot up and down. And if you don't have somebody to help you out, you guys can just do this right here in the chair. Gently move your foot up and down. Now remember our guidelines. Slowly and gently up and down. If you're doing it fast, you're going to trigger that spasticity. Passive range of motion of hip rotation. Now I've got it with the leg bent and with it straight. So this is with the leg bent, so you guys would have more success if you were laying down. So we're just going to show you guys this one. You're going to grasp the leg under the calf and under the thigh. Lift the leg up, bending the hip and the knee to 90 degrees as shown. And keeping with the hip and knee bent, you're going to rotate the hip in and out by moving the lower leg side to side. So you can kind of see this with the picture right here. But what she's doing is she's moving the hip in and out this direction. And that's working on your hip rotation. Okay? And with it straight, it's straight out this way, and you're turning. Yeah, if you're sitting in the chair, you can kind of kick your leg out straight and rotate that foot in and out. Heel slides. How many of you guys done heel slides? Those are a therapist's favorite. So place your hand under the thigh or knee if you've got help. Place the other hand under the arch of the foot and slide that heel toward your butt through the available range of motion. So remember, we're going to hold at that end range. So take that heel and you're gonna slide it up through your butt. I saw Liz helping you guys through this one earlier. So you're gonna, in the chair, slide that heel out and in. There you go. I love this one where he's using his other foot to help slide it back. Excellent. Now remember, what are our rules again? Gently, slowly, hold at the end range. And we're never gonna jump on that leg real fast and jump off real fast. This is working on your passive range of motion of bringing that hip out to the side. You're gonna place your hand under the thigh, near the bend in your knee. Place the other hand under the calf. Keeping the knee straight, move that leg out to the side, and then move the leg back in toward the starting position. Again, move it out to the side until you kind of feel that tug a little bit. Hold it at the end range, and then pull it back in. Good. All right, now we're going to move up to the arm. So with the person's arm at their side, we're just going straight up. You're going to go with the thumb pointing up toward the ceiling, and you're just going to go straight up this direction. And keep that elbow straight. That's the tough part. So start with your elbow straight toward the bottom, as straight as you can get it. And you're going to go straight up this direction. Very good. Now, if you have trouble lifting one arm, I see some of you guys using the other arm, as I know therapists have shown you. Joyce, you're doing a great job having one arm help the other arm. You guys all see Joyce doing it? That's excellent. Nice job. These we call snow angel arm raises. Very similar, only you're going to bring it out to the side. So on these, your thumb points up toward the ceiling. That way you get that rotation in the shoulder joint. And you're going to bring it out to the side. Good. And out this direction. If you don't have someone to help you with this one, and you're using your other arm, bring it to about 45 degrees. That way you can use your other arm to help you, and then you can bring it up this direction. Nice job, guys. Look like you've done this before. Okay, now this one, don't start this one just yet, because I see you guys are starting some of these right as soon as you see the picture. This one is not advised for people that have a hemiparetic arm. Do you guys know that term? So that's the involved side of a stroke. So if you guys have had a hemiparetic arm where that arm's really involved on your stroke side, it's not advised because we worry about that shoulder subluxating out of the shoulder joint. So if you have general spasticity in your arm after a stroke, ask your physician or your therapist before doing this one because we worry about that shoulder joint being intact. So this one's with caution. But this one's the elbow across the shoulder joint, stretching out the back part of that shoulder. But again, ask your therapist or your physician before doing this one. This one's shoulder rotation with the person's arm at their side. Bend the elbow, keep their elbow at their side when doing this, and you're going to move the forearm across their stomach and then out past their elbow if they're able to. You're working on that rotation. Good. This can really help for anybody that wants to get back to throwing that ball again. Working at your rotation. Your bicep curls. So you're going to move the person's arm to their side and support at their wrist. The wrist support's really important in this one so that the wrist isn't getting floppy. I have so many occupational therapists that always comment about that. You don't want to forget the hand, okay? You want to bend and straighten at the elbow, okay? Making sure to support the wrist the whole time. Good. Very good. Forearm twist. Be careful not to over twist with this one. And remember that your patient's sensation, if you're helping someone with this one, isn't always intact. So don't over twist on this one, guys. With the person's elbow bent, hold onto the wrist again. Don't forget the hand. Gently twist the forearm so that the palm is facing. So you're going from palm away to palm facing you. That's what we're aiming for here. Yeah, very good. That looks great. So what this can help with is things like grabbing your food off a plate, bringing it up to your face, grabbing that awesome cup of coffee, right? Wrist up and down, bringing your wrist down and then all the way back up. This is a favorite. All of these exercises too, these stretching exercises, if you are using bracing, should be done before you put your hand, arm, leg, ankle into the bracing. Because you want to stretch out as much as you can before you go into the brace. This is our last one. Place your hand on the back of the person's fingers. Gently bring those hands into a fist. And then back out. Good. We always shoot for 10 of every exercise, and then again, remember our rules. Gently, slowly, hold at the end range. Come on, real slow, and then let go real slow. Always shooting for those pictures that I showed you guys. I'm sorry, we've got one more. Those thumbs. So when we go against the thumb, shoot for that L position right here. You want to bring across, try to aim for your pinky, and then bring right back again, shooting for the L position again. Yeah? I used to be able to say it so that you could like hail a cab, and then Ubers became a thing, and you know, now it's not a thing anymore to hail a cab anymore. So remember, controlling spasticity, we can't get rid of spasticity, but it is in your control. How you do it, how much you do it, what limbs you're controlling, you know, what are your goals? Do you want to be able to open doors? Do you want to be able to drink that cup of coffee with that hand again a little bit better? So what are your goals? Spasticity can't be stopped, but it can be reduced by performing stretching exercises daily. Stretching the muscle can lengthen it, but it also needs to be strengthened. So I'm going to say that again. Stretching the muscle is important because it needs to be lengthened, but it also needs to be strengthened. So you need to exercise the muscle to make it stronger as well. Spasticity sometimes can give you a false sense of it being strong, so make sure you're making it strong too. Exercise is the key to mobility and comfort. All therapists are a little biased in that sense. So talk to your provider and tell them your goals. Any questions, guys, for Dr. Herman and I? Yeah.
Dr. Herman, they give me a new stuff called New Sport. Have you heard of that?
New sport.
Instead of Botox.
Dysport?
Dysport, that's
Yeah, I am familiar with that.
what do you think of it?
So, you know, as far as the studies are concerned, there hasn't been one agent or toxin that's shown to be superior to another for spasticity. I've heard in talking to other providers, just by way of their own experience that some patients will respond more favorably to one toxin versus another. Some have also noted that maybe after receiving a certain toxin for a long period of time, for whatever reason, the body doesn't adjust or respond as well, and that might be indication for trying a different type of toxin like Dysport. But unfortunately, there's not a clear answer as far as one is better than the other necessarily.
But is it Dysport like half the cost of Botox?
So I'm not as well informed about the cost because so much of it is dependent on insurance coverage and what your particular provider will pay for and what they've negotiated with the pharmaceutical companies and hospital systems. So yeah, that's as good a reason as any, honestly. If there's one toxin that is significantly cheaper for a patient, then without clear evidence that one is better than another, I would endorse going with the cheaper option.
Because I find that it's the same, and they said that it's about half the cost. So.
Yeah, that's excellent. So I think that's a good lesson for other patients. You can always ask as far as the cost. I know the healthcare system is not the most transparent as far as what particular cost will be, and oftentimes, I'll admit, even as a physician, we don't have the answers. So your provider or healthcare system will have counselors, insurance companies have representatives that can help you navigate through the costs of these procedures.
Well, I get mine through the VA, so you know that we're.
Oh, you're set, VA, yeah. You've got the golden ticket then. Okay. Any other questions? Sure.
You say cold is good for spasticity.
So,
How about heat?
so heat actually is my preference. Megan, I'll let her address as well, but yeah, heat is typically what I associate with having a better response for the muscles themselves. A lot of patients will benefit from a warm or hot shower in the beginning of the day to try and loosen up before they get on with their day-to-day activities. So heat is typically what I recommend. I'm sorry if I misspoke and said cold earlier, but
It's funny, the research always says cold, but clinically, I've always used heat as well. If you think of what relaxes you, you think heat. What I've always used over the last almost 11 years is what works best for the patient. And so we'll try both, and whatever calms the muscle down best is what we'll go with.
cold is good in the sense that it's kind of the natural anti-inflammatory. So if your muscles are overexerted and inflamed, and from that perspective, it works in a similar capacity as, for example, an ibuprofen or a leave that you might take. It kind of calms down some of the body's inflammation. So I think there's a role for both, honestly. Yes, sir.
My wife has a problem with what we call startle reflex that she didn't have before the stroke.
It's funny, do you remember the two pictures that I showed? Spasticity seems to be so directly related to our emotions that, again, think of what your emotional response is in traffic, where your muscles, you're so heightened that if she has spasticity, you're gonna be so much more heightened afterwards. That might be part of it. I don't know if Dr. Herman, you can talk more to that.
And there's also a distinction between spasticity and a term that we call dystonia that can seem clinically to be very similar, but they're actually different conditions. If you recall, I had a graphic kind of an arrow with kind of different types of tone abnormalities. So dystonia is separate from spasticity, and how we describe that is basically when you're getting co-contraction of two muscles that work in an opposite fashion on the same joint. But to answer your question, kind of take from what Megan said, there is definitely a behavioral component to that type of tone issue that, or condition that is present. That being said, the treatment is very similar to what we offer for spasticity, but there are some different types of medications that have shown to be more effective for dystonia rather than spasticity.
Spasticity, guess, really anything to do with your voice.
Yeah, it certainly can, and that's,
I didn't know that.
yeah, it's treated differently from a therapy perspective. And so that's when we may have our colleagues from speech language pathology help to perform some different types of exercises and treatments, because you're using your muscles to produce speech just as you are to perform other gross movements or fine motor movements. So it certainly can. Yeah, right.
Absolutely.
None of it is good. There are very few instances in which spasticity is good. I'll tell you what, I'm going to leave some of my cards on this table over here. I work over at the main campus at KU. I work in the spine center, which is kind of confusing, but I'm a general rehab doc, so I have my nurse's number on here and a scheduling number as well. So I'd be happy to visit with any of you all to talk about particular treatment options, ranging from therapy to some of the more interventional treatments that I discussed today, or just to have a general rehab doc that you can check in with on an annual basis, just to make sure things are being treated appropriately and you feel like you have someone that you can talk to about rehab. I hope all of you have a primary care physician, and some are more comfortable than others as far as treating the specific symptoms and consequences of stroke, and that's really where my training is geared to try and help patients who've undergone any kind of neurologic injury such as stroke. So, okay? All right, thank you all.